So be presenting a case that we saw recently in the Annapolis clinic. So this is a 50-year-old female. She was presenting for a follow-up visit. She's been having worsening cramping, aching pain bilaterally, restlessness throughout the day, but more at night. She has bilateral edema. It's worst on the left. And all these symptoms have been present for years now. She initially established with us in 2018. And on her initial consultation, she had mild venous insufficiency. Symptoms currently are moderate, occur throughout the day, interfere with her sleep as well. Alleviated by elevation and compression, aggravated by prolonged sitting and standing. She works as an executive assistant, so she spends most of her time at a desk, so it has been kind of interfering with her work with the amount that she's been kind of having to sit throughout the day. She does use compression stockings, been using the 20 to 30 for years now. Review systems were, all the other systems were negative. She does have a past medical history of lymphedema, mild chronic venous insufficiency that was initially noted in her consultation back in 2018, obesity, GERD, May-Thurner syndrome. In terms of her surgical history, she's had a bilateral mastectomy, cholecystectomy, and carpal tunnel release on her right hand. Non-smoker, occasional alcohol use, family history of lymphedema, hypertension, mentions that her parents had varicose veins, not currently on any medications and no allergies. A little bit of her past medical history continued. Like I said, she established back in 2018. We opted for conservative management at that time as she had mild insufficiency in her superficial system. She was sent for a lymphedema evaluation and a CVM referral because on her initial visit, she had mentioned pelvic symptoms, pain, bloating. And then her initial visit at CVM in 2018, at that time, she didn't want to go any further in terms of getting a stent placed or having venoplasty or anything like that. She did return in April of last year with worsening pelvic pain, bloating, and dysmenorrhea. Her OB workup had been negative. She did agree to have a stent placed, and she had a left-sided stent placed, IVC, left common iliac, external iliac, placed in May. Since her initial consultation in 2018, she was prescribed a lymphedema pump. Most recently, she used it about 2 times per week, about 30 minutes at a time. She hasn't had any superficial venous procedures done, and she's got no history of DVT. Physical exam, pretty much normal, 1+ pitting edema bilaterally, no skin changes. In terms of her BMI, it was 36.9. She's 5'4", weighs 215 pounds. And then as you can see, no skin changes, just edema. And then she's got swelling at the dorsum of her feet as well too. And so this was the scan that was done most recently on her follow-up visit. Previous scans, the one back in 2018, and then she had another one in 2019. There was pretty much no reflux in the GSV. She had some tributary reflux initially, but when she came back more recently, she's got bilateral GSV insufficiency and some tributaries on both sides as well too. So our plan for her was to do venous seal of the right GSV junction, the prox calf, and venous seal of the left GSV junction, the prox thigh, and then above the knee to prox calf, and then use Varithena on the tributary veins, and also to do a CVM follow-up. She had initially followed up last year in April, had the stent placed in May. She had her 1 week and 1 month follow-up, but after that, she had missed her 3-month follow-up after that. So her last follow-up for stent surveillance was back in May of last year, or June of last year. So initially, we did the first procedure, the venous seal, the right GSV, 25 centimeters treated. Distal GSV was treated with 0.5% STS, 1 cc. No issues during the procedure. And the follow-up, the right GSV is occluded, no EGIT, nothing out of the ordinary there. And then we treated her left GSV. Access was 3 centimeters below the knee. Catheter sheath placed at 7.65 centimeters from the SFJ, 1 cc of adhesive and 35 centimeters of GSV treated. So then when she followed up for her post-ablation scan after the treatment of the left GSV, was occluded. However, there we did see a EGIT level 2 at the SFJ. She wasn't having any symptoms. She wasn't really having any pain or extra swelling or anything out of the ordinary there. So we decided to have her follow up within 7 days for a repeat ultrasound. And this was the scan that we saw at the first post-ablation scan. This was 5 days after the procedure. And so then after, on her next follow-up, for the follow-up on the EGIT grade 2, she comes back about 2 to 3 days later, I believe. And now we're seeing extension of thrombus into the common femoral, and still no symptoms reported. We start her on Xarelto. And so this is kind of what we saw on the follow-up after we brought her back 2 to 3 days after that initial post-ablation scan. So as you can see, we can see some extension here. And then she did have a follow-up about a week. We had 2 more follow-ups after that. The next follow-up, we saw some P-throm at the common femoral vein. And then the follow-up after that, she continued to remain on Xarelto. And then there was no occlusion 2 weeks later at the left CFV. We could see the adhesive just kind of come almost close to the junction. So in terms of glue-induced thrombus, there are no clear management guidelines for this. Most have adopted the EGIT protocol for treatment of cyanocalite-induced thrombosis. So grade 1 and 2, either you can do serial scans or antiplatelet therapy, and grades 3 and 4 can start anticoagulation, as the extension of the adhesive into the deep system can kind of serve as a precursor for DVT due to flow obstruction. So trying to look through risk factors, incidence of glue-induced thrombus. This first article done by Dr. O'Banian, and it was done at UCSF Fresno and MedStar Washington Hospital Center as a retrospective review of 2 tertiary academic centers, total of 803 patients that went through 1,096 procedures. 396 of these were venous seal, and they found the EGIT incidence at 1.3%. But they couldn't really find any significant risk factors leading to thrombosis. Most of the glue-induced thrombus, the incidence of this has usually been related to inadequate compression with the ultrasound probe when administering the adhesive. And then Dr. Joe, he did a single center retrospective review. There were 191 patients in this review, and 11 patients ended up developing glue-induced thrombus, grade 1 and 2. None of them developed a 3 or 4. 0 of these patients were on anticoagulation. And based on their review, they mentioned that potentially a risk factor for glue-induced thrombus was a smaller diameter of the vein, less than 5 millimeters. I tried to kind of look in further on this paper to see why exactly they thought that a smaller diameter may be considered a risk factor for the glue-induced thrombus, but they didn't really go into too much detail. They just had mentioned that of the patients that they had developed a thrombus, that this could potentially be a risk factor. And then this is another single center retrospective analysis performed on 76 GSVs from February 2016 to December 2017. 7 instances were detected among 54 patients, so 13%. The glue-induced thrombus usually resolved within observation period of 5 weeks after detection without DVT or pulmonary embolism. And based on this study, the EGIT was associated with significantly greater mean age of at least over 70, based on the paper that they wrote. So Dr. Stewart and I kind of went over why we thought, what may have caused it in our case. And, the patient did have a BMI of 37. And even with the attention to compression with the ultrasound probe, what we thought may have happened is that even with the compression of the ultrasound probe, just due to her body habitus, I don't think we were able to get enough pressure to collapse the GSV at that specific point. And so then when we administered that adhesive, even though we may have seen like it was complete compression of the GSV, looking at the ultrasound while we're keeping the probe on the GSV, some of the adhesive may have slipped underneath in that area where we're compressing, leading to the thrombus that we eventually ended up seeing. But in terms of follow-up of the patient, she seems to be doing well. No real symptoms were reported. And then we had her on Xarelto. Some things to consider in this case is in the common femoral vein, we don't see anything on the most recent scan, but we do see the adhesive pretty close to the junction. So how long do we keep this patient on Xarelto? In patients with large body habitus, especially like large proc size, is it good to do even venous seal on these patients, considering we may not be able to get good compression? And another thing with this patient is that back in 2018, she was very negative on our initial scan. She only had some tributary reflux. She comes back in 2019, still not a significant amount of reflux. She ends up getting the stent last year, and on the most recent scan, which was within the last couple of months, and this is post-stent, she has a significant amount of reflux bilaterally. So what happened in the last couple of years were the first scans, technically difficult scans, and we didn't really catch most of this reflux. Why is there more reflux after the stent? So these are some of the things that me and Dr. Stewart discussed. So this is a pretty short case, but it's just something I wanted to kind of present. We don't see glue-induced thrombus too much. So anybody have any questions, remarks?
Why did she have a bilateral mastectomy?
I believe, looking back in the notes, she was BRCA positive.
Thank you.
Did she have the situation with her anticoagulation after the stenting? How long did she have?
She did have anticoagulation after stenting. I believe she was on Eliquis.
the question of follow-up in the sense that she did not have recent follow-up, if I understand you correctly, do we know the status of the stent now? Sometimes, stents can get into problems and they can get compression, they can get occlusion. So what is the stent doing now?
Right. So her last follow-up was in June. And this procedure was done within like the past month or so. So currently, no, we told her that she needs to definitely come back to CVM as soon as possible just to see what's going on with the stent.
As far as comparing EGIT with EGIT, it is very tempting to do so, but the pathology of EGIT is truly heat-induced. And as you guys know, we have written multiple papers and large series on EGIT. But EGIT does not have any heat, and therefore it is a propagation of the glue that may cause thrombus. And as far as the treatment, we stopped treating a long time ago for EGIT-2, and this has been accepted now by everybody, and EGIT-3 and over should be treated. Similarly, since we really don't know, and about with EGIT, it may be behaving like true thrombosis, and as such, treating the person properly at 3 is reasonable and good idea. Question is, now that it is like EGIT-1, because it's right at the junction, at that moment, I don't know whether it should be stopped or not, because if it is EGIT, we definitely don't need to treat that. And my feeling is that she will do very well. And one of the paper you cited had a higher number of EGIT of 7.8 or something like that. And that is including 1, 2, and so on.
Yeah.
Truly, whether it is EGIT or EGIT, level 1 is really completely meaningless, and it should not really be considered as any risk. Anybody has question for?
Dr. Sufyan, I'm Mohammed here. Why would the Xarelto affect glue propagation?
Yeah, I know definitely with heparin, the propagation of the clot is definitely affected, and it is very useful. If this is true thrombus, I think it would just have, the person will kind of resolve the clot, and I don't know whether it's truly due to the Xarelto or by the natural phenomena of the patients doing the resorption.
Hey, this is Dr. Stewart. Good job, Dr. Patel. One interesting thing with this is that, are we seeing the actual glue go into the common femoral vein and then kind of contract back? Or is this a true thrombus that was induced by the glue? And on ultrasound, it's hard to tell if this is a thrombus or if this is just extension of the glue. I feel because of the resolution after 2 weeks on Xarelto, it was probably a true thrombus. And it may have been impacted by the venous outflow obstruction that she has as well, as Dr. Sufyan alluded to. After the thrombus resolved back to an EGIT-2, we took her off the Xarelto after 2 weeks, and she's done fine since.
Yeah. I agree with you, Dr. Stewart. That's very reasonable, and it is very unlikely that the glue will reabsorb if it was truly a glue that went into the femoral. It is very, very likely, and it's almost certainly that it is a thrombus that has developed. Exactly why it has happened, it is hard to say, but it is not like EGIT. EGIT is heat-induced, and it affects the lining of the wall, etc.
Yeah, that makes sense.
Sean, would you, or Dr. Sufyan, would you comment on maybe a way to discern this being a clot versus glue propagation following a D-dimer?
To be honest with you, I have not seen any paper or any publications, maybe I missed it, is that we really need to know the true pathology of this thrombus. Early on with EGIT, it was done, and we know definitely the thrombus that develops after EGIT is not like the classic thrombus that we know about. But with EGIT, I have no idea, and this is one thing that somebody has to develop a model either in an animal or remove it somehow and compare the pathology of these two thrombi that develop for two different procedures. One is heat-induced, the other is not.
Good morning. This is Fernando Alesquez. In Connecticut, within the last 6 months, we reviewed the number of EGITs that we had because it was significantly greater. And one of the things that we took away from that was that post-deployment of the glue and post-procedure, we take an image of where the glue is in relationship to the junction. If you see that the distal portion of the great saphenous vein is free of glue, that gives us some comfort that on the follow-up, if we do see extension into the deep system, then it most likely is thrombus, versus if you see the glue very close or even into the deep system, then we get more concerned that this is indeed glue extending. The other thing with ultrasound is, and I think in your image, occasionally the decreased echogenicity of the portion that you see in the deep system, to me suggests more thrombus, as in this case with resolution of Xarelto, versus actual glue, which typically is much, much more echogenic. That's not always true because obviously thrombus can be echogenic, but it does give some, I think, indication and at least some comfort that if it's thrombus, it will respond to Xarelto. Thank you.
Fernando, I agree. I'm sorry, Dr. Sufyan. I agree with Fernando's, because in this case, if you look at the possible thrombus, it wasn't as echogenic, and it was more. It just wasn't consistent with its echogenicity, and that's what made me feel that it was more of a thrombus. One other quick comment is in terms of why smaller diameter GSVs may be more susceptible to EGITs, is if you think about it, if you have a small straw and you put a drop of glue in that straw and you compress it, the glue is going to kind of go both ways. So that's why the proximal compression is so important, but sometimes that can be incomplete to prevent glue from seeping past your proximal point of compression. If you have a bigger straw and you put the same amount of glue in and compress, you're not going to get that same pressure that pushes the glue more proximal, because we're just deploying the same amount of glue regardless if the GSV is 4 millimeters or 12 millimeters. So that's I think why you get more risk of EGIT if you have a smaller diameter GSV.
I just have one warning to everybody. When you have an EGIT or an EGIT now, and you know it is level 2 or 3, in follow-up, please be careful not to compress that, because in other words, if you want to try to compress to know whether this is a thrombus that is compressible or it is the echogenicity level, it is very dangerous, because we reported the first case of compression caused pulmonary embolus many years ago, and that has been published a long time ago, and everybody knows about this now, because when you compress, you can fragment that and it can cause definitely pulmonary embolism. Once you see it, it is better to plan for the treatment accordingly.
Fernando, that's so true. Fernando again here. I have a question going back to the description. You mentioned that the stenting was IVC and iliac veins. Do you have any more detail to the extent? Because it seems that if at that time, and this is obviously in retrospect with 2020 hindsight, It seems that if there was no reflux in the extremity veins post-stenting, could this be occluded involving up into the IVC and thus causing reflux? And the question becomes, after successful treatment of the saphenous veins, if the outflow is impeded, I think the edema may not resolve, and in fact, there may be more problems. And as such, I would think that we would want to look at the patency of the stents. Thoughts?
No, this is Dr. Stewart.
Yeah.
Fernando, I agree with you. And this is, interestingly, when she came back to us and presented, it wasn't because her edema worsened. Her edema actually was better after the stent and after lymphedema therapy. What she came back to us for was restlessness and cramping, but there was an improvement in her overall edema. So when we set her up for these treatments, we were more focused on what we thought was either new reflux, or we thought that the initial study may have been compromised by the amount of edema she had initially. But absolutely, looking back on the case now, probably if I were to do it again, I would get her this, some surveillance on the stent prior to starting her superficial treatments.
Right. And sometimes, with greater discussion on the pathophysiology and discussing reservoirs and discussing compensated and uncompensated, even when there is occlusion, let's say, of the stents or the outflow, if it's compensated via more collaterals, one may not see any true physical changes. So I think it would be very interesting to see on the follow-up what is seen regarding the patency, and certainly re-intervention and redilation would probably help her if it is somewhat closed or indeed closed. Fascinating case. Thank you.
Very interesting.
I had one question or comment. This is Dave Calcagno. Can you hear me okay?
Yep.
Just with respect to that 5 millimeter thing near the junction, from that standpoint, and also it's digressing a little further down the extremity, but a lot of patients have, maybe a large saphenous vein where you're in several sections and not so large in other spots. But I know the FDA thing says how much glue you squirt in each spot, and we try to follow what they tell us to do. But I think you have to use some judgment. I think if someone has a particularly small GSV, and you can tell that as you're, if you're putting your sheath dilator up and they're having pain or resistance, that, that vein's not that big in that section. You have to kind of maybe use a little art to change how much glue you put in. Because I think if you put a lot of glue, or the standard amount of glue rather, in a small vein, it's going to squish forward like with your EGIT. And if you do it in the mid thigh, I think you might see a lot more glue get squirted out into the tributaries and cause redness along the course of the vein. So I think I don't think we want to follow the rules, but you have to use a little judgment. That's it.
I think that's a great point. And sometimes what I'll do is I won't deploy glue every 3 centimeters as we pull back, but maybe at every 5 or every 6, again, depending on the size of the GSV.
Exactly. Thank you.
Thank you, Dr. Patel. This was a very nice presentation, and the time is now 7:32. So unless somebody has very important question, we can bring it to close.
All right. Thank you, everyone.
Thank you, everybody.